Hello, in this video I would like to talk to you about lung protective ventilation. The following slides are modified after the ARDS-NET protocol. You can see the protocol at the ARDS-NET website. The link for the PDF is provided below. So the lung protective ventilation is recommended in patients who have acute respiratory distress syndrome or ARDS. The definition criteria for ARDS are the following. First, there should be evidence for hypoxia. Based on the PO2 to FiO2 ratio, this is less than 300. So the pressure of the oxygen divided by the fraction of inspired O2 should be less than 300. There should be an evidence of bilateral patchy, diffuse, or homogeneous infiltrates consisting with pulmonary edema. And there should also be an evidence that the pulmonary edema is not hydrostatic, i.e. it's not due to heart failure. So no clinical evidence of left atrial hypertension. When doing the ventilator setup, you first want to go by the predicted body weight, not the actual body weight. And below are two formulas to calculate the predicted body weight for males and females. Next, you want to select the ventilator mode. In the ARDS-NET protocol, they don't specifically recommend any initial ventilator mode. However, I find it easy to start with the volume-controlled ventilator mode, as it allows you to directly control your tidal volume. Next, you want to initially set up your tidal volume at 8 milliliter per kilogram for predicted body weight, and then you would want to reduce that as tolerated by the patient. You also want to increase the respiratory rate in most cases in order to maintain baseline minute ventilation, and you adjust the tidal volume and the respiratory rate to achieve your pH and your plateau pressure goals. When it comes to the oxygenation, your goal PO2 is 55 to 80 milliliter of mercury, or oxygen saturation between 88 to 95%. The minimum PEEP that's recommended is 5 centimeters of water. The ARDS-NET provides you with two tables to help you up-titrate your PEEP as you are up-titrating your FiO2. There's a lower PEEP and a higher PEEP table, so that's the first table here, the lower PEEP, and then that's the higher PEEP table. I actually prefer to use the higher PEEP table in patients who have severe ARDS. So for example, let's say you increase your fraction inspired O2 to 0.5 or 50%. If you're going by the lower PEEP table, you have to keep a PEEP between 8 to 10 centimeters of water. If you're going by the higher PEEP table, then you would want to use PEEPs between 16 to 18 centimeters of water. Next, you want to check your plateau pressure initially, and you want to check your plateau pressure as you're making adjustment in the ventilator setting. Your goal plateau pressure is less than 30 centimeters of water. If you achieve your goal plateau pressure, then you have some leeway and you can potentially increase your tidal volume if needed to keep the patient's acid-base status acceptable, or if the patient has ventilator dyssynchrony. When it comes to the acid-base status, ARDS-NET recommend a pH goal of 7.3 to 7.45, i.e. it's okay to have the patient on the acidotic side, and hence the term permissive hypercapnia. In terms of acidosis management, they recommend to increase the respiratory rate for acidosis as long as the respiratory rate is less than 35 breaths per minute. If the patient is severely acidotic, then you may increase the tidal volume, even if that means exceeding the goal plateau pressure of 30 centimeters of water. They also recommend using or consider using sodium bicarbonate if the patient is severely acidotic. If the patient has alkalosis, then they recommend to decrease the respiratory rate. They also recommend to use a physiologic inspiratory to expiratory ratio, meaning that the duration of inspiration should be less than the duration of expiration. So that's a brief overview of the ARDS-NET protocol. Next, I want to show you a case, and we will go through the case and adjust the vent setting on the simulator. So this is a 50-year-old female with acute respiratory distress syndrome, or ARDS. The patient's height is 170 centimeters. The patient's weight is 75 kilograms. And that's her initial ABG, pH of 7.28, PCO2 of 54, PO2 of 65 on 50% FiO2, and bicarbonate is 25. So initially you would want to set the initial ventilator mode, set the initial tidal volume, check your plateau pressure, and also up titrate the respiratory rate to keep the minute ventilation. So that's our initial setup. I will go over it as we set up the ventilator. So I will move now to the ICU Learning website, scroll down to the mechanical ventilation section, and then you'll see the preset scenarios. If you don't see them, then that means that you have to log in. Once you're logged in, you should be able to select one of those scenarios. I will go ahead and select the restrictive process, or ARDS. It's already open here, so I will move to the simulator section. So the initial settings for the ventilator is volume control. So the ventilator is already set up to use volume control. The respiratory rate is 12, the PEEP is 5, the tidal volume is 500, and the flow is 60. So first, as you can see, the tidal volume is higher than what's recommended based on this patient's predicted body weight. Second, the peak pressures are elevated at 45 centimeter of water. I will go ahead and check my initial plateau pressure here. So I did the inspiratory pause maneuver, and this gave me that plateau, that flat line. As I hover my mouse over it, I know that the pressure is 34, so that means that my plateau pressure is 34 centimeters of water, which is higher than what's recommended. So our patient here has a predicted body weight of 61 kilograms. And so 6 to 8 cc's per kilogram ends up being between 370 to 490 milliliters. So she's already exceeding that in terms of her tidal volume. So I will go ahead and decrease the tidal volume, and let's try 400 milliliters. I'm already on volume control mode, which allows me to directly control the tidal volume, so that's good. And I also want to pay attention to my baseline minute ventilation. So before I made the changes, the patient had a respiratory rate of 12 breaths per minute and a tidal volume of 500. So that means that I have a tidal or a minute ventilation of 6 liters per minute. Since I decreased my tidal volume to 400, I would want to increase my respiratory rate to keep my minute ventilation about the same. So I'll go ahead and increase my respiratory rate to 50. And now I will resume the simulation. So now that I made those changes, I want to check my peak pressures and my plateau pressures to see if I was able to achieve my goals. So I plan to check my plateau pressure with the next cycle. Okay, very good. I will go ahead and pause the simulation by clicking on the screen. And then I will hover over that flat plateau line, and then I see that the pressure now is 28 centimeters of water. So that means that my plateau pressure is 28, which is at the goal less than 30. Very good. So I am done now with the initial setup. Again, to summarize, I decreased the tidal volume to achieve a goal of 6 to 8 milliliter per predicted body weight. Second, my plateau pressure now is less than 30. And third, I kept the minute ventilation at the baseline by increasing the respiratory rate after decreasing the tidal volume. Next, I want to pay attention to my oxygenation. So in this case, I gave you the ABG. This patient had a PO2 of 65, which is acceptable. However, if you note here, the PEEP is 5 centimeters of water, which is lower than what's recommended. If you go through the table, if you go by the lower PEEP table, then you see that we need to at least 8 centimeters of PEEP. If you go by the higher PEEP, then it's 16. So let's stick to the lower PEEP table for the sake of simplicity here. I will go ahead and increase my PEEP to 8 centimeters of water. And then after making the change, I also want to recheck my plateau pressure. All right, very good. I will go ahead and pause the simulation and then hover over that flat line. So note now that my plateau pressure is 32 centimeter of water. So this is higher than what's recommended. So in order to help with that, I will go ahead and decrease my throttle volume further to 370. All right, very good. And now you see my plateau pressure is 29, so that's acceptable. So now I have achieved my tidal volume goal. I've also achieved my minute ventilation goal. I've achieved my PEEP and oxygenation goals. Very good. Last, when it comes to the acid-base status, our initial goal was to keep the minute ventilation the same, which we did by increasing the respiratory rate. However, note that for this patient, the patient has a component of respiratory acidosis. And so in order to help improve the respiratory acidosis, you can further increase the respiratory rate. And in this case, since the current PCO2 is 53, and if our goal is to normalize the PCO2 to a normal of about 40, then that means that we need to increase the minute ventilation by 20%. This is because the PCO2 and the minute ventilation are inversely proportional. And so 40 is about a 20% decrease from 53. So that means that I have to increase my minute ventilation by 20%. And so that ends up being 7.2 liters per minute. That's a 20% increase from 6 liters per minute. So in order to do that, I have to increase my respiratory rate to 20. So I go ahead and pause the simulation. Increase my respiratory rate to 20. And go from there. In some patients who have obstructive lung disease like asthma or COPD, you want to pay attention to auto PEEP or air trapping, as increasing the respiratory rate will put them at a high risk of having auto PEEP. In this case, the patient does not have any obstructive lung pathology, and hence there's no problems with auto PEEPing. At this point, I am done with my initial setup for lung protective ventilation. I will pause here and thank you for your attention.